Oh, sorry, I forgot about that. I think it's a short talk because there's not a lot known. No, you're good. Keep going. My disclosure is that some days I think I know what autism is, and other times I'm super perplexed. So that should bring fear, I guess. Next slide, please. So we want to today talk a little bit about the development in children with autism spectrum who are deaf and hard of hearing, look at some imitators, and then look at the challenges and gaps in treatment approaches for kids who are deaf and hard of hearing, with autism. So one of the ways I like to start this talk is really thinking about our evidence-based framework. So when you think about the strongest level of evidence to the weakest, our opinion and case series are helpful but not very robust. And then we move into cohort studies or comparison groups or randomized controlled trials. And when we have enough studies, we can collectively put those studies together, which is the most robust quality of evidence. And unfortunately for kids who are deaf and hard of hearing with autism, we are largely at a case series level of evidence. Next slide, please. So since we don't know a lot, what do we do? I think where I start focusing on is typical and atypical language learning. And what is foundational to learn language? Next slide. Sorry, I probably didn't need to do that one. So these are two different visuals of how people have framed up what is important for language learning. With one focusing on attention and listening first and play and interaction second, followed by comprehension, expressive language, and speech. And the other framework has interaction as first, and then play, and then attention, looking, and listening, followed by comprehension and expressive language. And I think these are both interesting models, and I don't know what's right. So I try to just have you guys think, what do you think is first? I do probably think interaction is pretty key in terms of when you think about infants and how we bond and attach. So I probably have a bias a little bit towards the second model. So when I'm going to go ahead, even though I kind of like that interaction one first, I'm going to take those headings and kind of talk about that and how it links to language learning. So we know joint attention is really foundational. And joint attention is when you and I are both attending to the same thing at the same time. And then we layer language and communication on top of that. And difficulties in joint attention is a core deficit in kids with autism. No matter if they're hearing, deaf and hard of hearing, visually impaired, that joint attention is key. And it is more than eye contact. And when I think about kids who are deaf and hard of hearing and why we need to think and why we need to intervene with families to assure they understand their child's needs for joint attention, is because we have to respect what they are processing in their communication. So I might be playing with something, they're going to look at it, but they may have to look back up. And it's almost like, I call that a double joint attention. It's not anything scientific, but it feels like for kids who are deaf and hard of hearing, we need to either make sure that communication is in their line of sight and or wait for them to come back to that source of information. Next slide, please. So I think the other thing when I think about joint attention is sometimes when I'm seeing kids who are struggling, we actually have to move backwards in order to move forwards. And that doesn't feel really great, but it's going to be the way to get you there. So again, I've talked a couple of times about I have vocabulary, but not conversation. Well, if I don't have conversation, it means I don't understand the give and take of communication. So we may have to go back to that 18-month concept. So not, like what do kids at that age like to do? They like bubbles. They like shared cause and effect, chase games, tickle games. How do I get something going that you like and enjoy and you can then communicate about or get that back and forth interaction? The other context we sometimes use is shaping behavior towards joint attention. So you have a kid that's really interested in the toy, but then you've got to bring that up to your face so that you get that better visual regard. Again, where can I put myself in play and wait for that response to reinforce that they are requesting again? Next. And the motivations are really key for kids with autism. So how do we know what they're going to be motivated to communicate about? And the other thing I learned from a speech pathologist was very interesting. She would often talk about an acceptable distance for joint attention. So for some kids, it almost felt like 3 feet back is going to be where I'm comfortable looking at you or looking at something shared, versus if you're really right next to me or in my space. Next slide, please. So again, I like my little cases. I had 2 little boys about the same time coming through for a cochlear implant. And this was probably in the year when we weren't doing around a year. It was, early, a little bit later age. So they were both about 2. They both did great on visual problem solving skills. Their engagement in what I was doing was easy. They were transitioning well. Neither one gave me good eye contact. When I look back at my notes, they really weren't looking up to me. Family engagement was good in both families, really. The one family had a lot of engagement by grandparents, and so that seemed to be strong. Next slide, please. So both did well with their implants with acoustic access. Next one. The first child eventually kind of took off on their comprehension, but their expressive language was delayed. And so he was diagnosed with apraxia. And probably, in retrospect, it was probably that he kind of recognized, if I'm looking at you, you're going to want to respond, and I'm not going to sure what to do. And he was also a little bit of a slow to warm kid. So that kind of, I'm going to watch before I jump in temperament. The second child, he adapted well to his implant, but his language really slowed and perhaps regressed. And I bring that up because in hearing children with autism, about a third of children do experience language regression, usually around 15 to 18 months of age. So he may have been lining up with that autism piece with his regression. They were concerned because he didn't interact well with peers. Again, that play and interaction. Why do we communicate? We communicate because we are trying to connect and interact with others. And one of the things that I do pay a lot of attention to play, because I think it's that natural window into what a child recognizes, might be thinking, if they're pretending or they're imitating and modeling. What you're seeing is this little boy going around a circle in his little vehicle. It's on the outside. He likes to go in circles, and often in gym, that's what he's doing the whole time when they have that free play. But what you're also seeing at that far end is a little game of duck, duck, goose. And so kids are, I don't know, that's going to be coming through very well. If we can't play it, that's okay. What happens is he stops and watches that game for a little while. I think he is sitting there at the far end just watching while the kids are going around and around. And if you think about it, he likes to go around and around. So when they showed me that, I did think, hey, this was an opportunity for an adult to help him integrate with that game, because it does leverage his motivation and it brings some of those social skills. So that was kind of a recommendation for that kid. So I know I'm a little bit flip-floppy back and forth, but I still kind of think through autism in those old school 3 different areas, but they've kind of consolidated them into 2. But it's really about atypical language. It's not just delayed language, but you're seeing things like echoing, scripting, or repeating things over and over it might actually fit the setting, like ready, set, go when I want to leave, but it is got the scripted quality. We often see limited gestures, difficulty with conversation, and difficulties in that social and interactive play. Yes, we can see things around eye contact and social reciprocity, and then we have that intense interest or preoccupation with things that are not typical. So it's one thing that you like Pokemon, but it's kind of different if you like fans, right? So that's just not something that most kids get interested in. So the DSM-5 criteria have changed a little bit, but it's basically deficits in social communication and social interaction. That's one of the categories. So it just went green. There we go. Okay. That includes things like social emotional reciprocity, that nonverbal communicative behaviors like gestures, and then developing and maintaining those those relationships at your developmental level. So that's our social piece. We've got our communication piece, and then that restricted repetitive interest. So these really are repetitive behaviors. They're stuck on routines in a way way that you can't really talk them through very well. Even if they have the comprehension, it's going to be difficult to shift and then fixated interest. I think a lot of kids who are deaf and hard of hearing likely probably links to, am I missing out on information? Am I comprehending? So again, that one to me, I always kind of think about in context. They did add sensory regulation kinds of things in the DSM. I will talk about that a little bit later. I think that was maybe that was an overarch a little bit, because you can't have sensory integration problems that are not autism, but I get why they did that. What they did also say in the criteria is that these need to be occurring early. They can't be from another reason. They've got to have a functional impairment. But they did allow, different from the prior diagnostic criteria, you can co-label ADHD or anxiety disorders, which I think was a benefit to kids with autism, because we saw those patterns, but it felt like you weren't allowed to call them. And then the other thing, I won't go too far into this, the other area that they added to DSM is the severity level or level of support. And that's helpful from a services perspective. And one of the reasons they broadened that collective of the DSM and no longer have Asperger's or a PDD is because sometimes those labels were not getting services. And in this way, we could kind of encourage people to think about what a child needs, not like, it is a severity leveling, but not because I'm cognitively capable or I have good communication. We still may have other significant needs. So for kids who are deaf and hard of hearing, I mean, we're kind of stuck, right? There's really not standardized assessment tools for them that are linked to autism. We don't have very many providers who evaluate kids with autism who understand what's impacted in the deaf, hard of hearing piece, and they may over attribute something like, they didn't look at me when I did testing, but they had unilateral loss. I'm like, well, that's, you've missed the boat on that one. Or, they may misinterpret a behavior that is actually related to hearing and audition and not autism. We also know kids act differently in different settings. And I sit in a clinical setting where we do everything with adults and we don't see the peer interactions. So we really do need to think about multiple sources of information. And there just aren't very many providers duly trained in deafism. So again, this is one of those areas where we need to collaborate. So the little guy who I was telling you about, the second one, he did get evaluated and did have autism. He met criteria. He still had very strong visual perceptual capabilities. So he could do a lot of matching and that sort of thing. Next slide, please. So he's the kid who we went, they were doing a lot of visual matching in therapy, but he could do that. It was just a task. So we really pushed them to consider true picture exchange communication system. And they did use some sign support. And, because again, he was kind of paying attention to some of that. He doesn't sign anymore, but that really was his bridge to oral communication. Oh yeah, and I talked to you about the Duck Duck Goose game. So get him playing with the things he likes to do. So I do like to talk a little bit about picture exchange communication because it is a highly structured intervention approach, and there are phases to that. And it does work foundationally on joint attention and turn taking. So even before you get to pictures, you got to give something to get something. Again, we're trying to get that foundation that communication is. You're not here just to do what I want you to or be my tool, but we've got to have this reciprocity. And then you build it up to sentence strips and so forth. What I often often families will tell me, oh yeah, they use pictures in school or in settings or in therapy. And I often hear the description of a picture schedule or work schedule. And those are very helpful, awesome tool. They are not a communication tool. They are there to help kids know what to expect and for us to get cooperation from them or compliance on what we're asking them to do. Unless we're setting that up as what are you picking as your order, it's really not building a communication system per se. Useful, very useful tool. So when I think about PECs, I do see sometimes we need 2-on-1 to build the skills. Some kids are already ahead of that. We don't need to use PECs. We have to think about what's motivating. We have to think about what they are processing. So do they understand what objects are and that they could ask for that using an object? Is a photo okay? Is an icon okay? We have to look at those things to build the system correctly. Sometimes too, we have to make it smaller and contextual. And how do we do that? Or, how are we going to use it across settings? And then a lot of families talk about how challenging it can be, even though they see it working. If it's a bulky system, how am I carrying that around everywhere? How am I making that work in my day-to-day life of, what I have in front of me and what we're trying to do that day? There is a really important shift to technology when kids do well with PECs, because when PECs can't keep up with the concepts, we need to be able to expand with the child's communication. And not all components of language can be easily represented through pictures. So especially as we're working on building sentences and literacy, that technology may get us a little further. Again, when kids are ready. So what's our level of evidence for kids who are deaf and hard of hearing? Well, you can hit the next slide, or you can hit it one more time. We have pretty much like a couple of papers, but I think too, what you really have to think about is augmentative communication. Often people think about it as a speech generating device, right? For kids with cerebral palsy, it helps you understand what they're saying. But it's more than that. And we have to think about it as a tool to build language. So when we're talking to families, there's a lot of things we have to also know. This isn't replacing communication or speech or signs. It's the tool to get us to the next place. So he's doing great. He's in his 20s. He still has a fairly significant language impairment. He does use spoken language fully. He's not a signer at this point. He does have an atypical prosody, so that's the vocal pattern of the speech does sound more like autism. That's a characteristic that many people who don't work with deaf and hard of hearing kids might not recognize, and that's a component of autism. So, is that the speech because of the implant or his prosody from autism? And he loves to fish, and he's actually quite independent and doing very well. So let's go to one more. For kids who are deaf and hard of hearing, this is true of any kid, right? So we've kind of hit on some of these, but when we see issues with joint attention, eye contact, if they're not doing a lot of requesting or showing, turn taking, choice making, those are the areas that are hard. I can't make a choice between two items. How do we get you there? I'm not turn taking. That's going to be super foundational for the next levels. This is just items from the MCHAT or the modified, MCHAT. Forget what that all stands for. Basically, it's an autism screening tool that we use in hearing kids. And the reason I like this slide is because these are the areas where if you're not doing it by a certain age, you're actually going to fail the MCHAT. And you can have problems in the MCHAT because of language impairment too. So it's not necessarily, it's a screening tool. We don't know they have autism. But there are very few things that don't apply to kids who are deaf and hard of hearing. So when you look at things like pointing, gesturing, pretend play, showing, those are all things deaf kids do, deaf and hard of hearing kids do. Eye contact. But turning to their name, sure, that might be auditorily driven if you don't have access. But, again, I think we need to really look at those core features and not just assume that we forget these tools. Next slide, please. So I have often looked for what isn't there. Look at the quality of communication and functions of communication. Again, I've worked with some amazing speech pathologists who helped me go think about what that kid talked about or what they tried to indicate. Was it to direct and regulate everybody else? That's all they were doing. Or was it to share? Like, I wanted you to see something. I want to share something with you. What does that engagement and play look like? Those things really qualitatively are important to recognize some of the challenges with autism. So in kids who are deaf and hard of hearing, you will see all of these. You will see atypical prosody. I didn't put spoken and sign, but sign, space, and shape and smoothness of the signing could actually probably be considered prosody. But you will see echoing, repeating what's said or spoken or signed, scripting in both, idiosyncratic word use in both. Aaron Shield has done tons in this area of deaf kids of deaf parents with deaf children with autism of deaf parents and looking at their ASL errors with pronouns, palm reversals, facial markers. You might think of that as an articulation error, but you could also see that as if I'm signing to myself, I'm not realizing I'm supposed to sign to you. So, it's that theory of mind piece that where I'm supposed to be conveying my thoughts to. So some red flags, I think these can also be not just autism, but, those more social pragmatic skills. And so you can see this challenges in kids who are deaf and hard of hearing without autism. But you really want to build these skills, right? Can I clarify if I'm not understood? Am I even aware that I've had a miscommunication? Integrating information is, you might do it well, not having very many ways to ask questions. Again, those functional skills of language. I can talk, but I don't converse. And then gaps in social reasoning. So kind of why would other people do what they're doing? Next slide, please. So a lot of times, again, I kind of think in sequential ways. So is my communication approach matching their learning strengths? If I'm using an auditory approach, is my amplification effective? Does it allow me to access that? If it's a manual approach, do I have a good exposure to sign language, a language model? Is my fine motor skills capable of forming those signs in an age-appropriate fashion? So, signing has a fine motor development aspect to it as well. Whole other talk. We'll do that another time. So, did you hear me? Did you understand me? Do you have the ability to respond appropriately? Those are great questions for any time you're trying to figure out why is a kid acting the way they are, right? Other kind of atypical language considerations, and Gens had this really great talks on deafness and autism. They have a book on vision impairment and autism, and this is really from them. Do they have trouble watching others as they talk or sign? Do they shy or avoid people? These are not characteristics that are typical for kids who are deaf and hard of hearing. Is that imagination and pretend play hard? Are you having to really teach phrases over and over and over to get that capability? What are, again, that restricted play? Am I playing with the same thing over and over? Can I expand you out? How movable are you? Do you follow that pattern of routine over and over and it's hard to shift? And then how upset do you get when the routine is changed? And again, I think about that. Sure, kids, if they don't realize, any kid, if I didn't warn you that in 5 minutes we're going to go and we're going to clean things up, and all of a sudden we're trying to get you out the door, they're not really ready for that change. So can they understand that? And, with those patterns, is that really still hard? Thank you for my couple of claps once in a while because I can't see people. It feels good. So the other thing I think about in adults with autism, they have sometimes said, when I look at you, I can't hear you. So what that tells me is just overwhelming. But if I look away, I'm better at listening to you. And yet we teach kids with autism, you got to look people in the face. Well, then they might miss out what they're actually processing. Again, when I'm thinking about a kid who's deaf and hard of hearing, I might, if they're signing, I might sign close to them, down by what they're doing. They may be picking things up visually, peripherally, that we're not realizing they are. You hear this a lot. Do you understand me or are you ignoring me? For kids who are deaf and hard of hearing, I feel like this is not founded in science either. This might be that low-level evidence. But sometimes kids seem deafer than their audiogram, right? They're not responding in the way you would think if they've amplified. Some kids do have those sensory issues of tolerating their hearing aids, but I've also had, families, kids with implants go, oh, when it's about getting something at a store, they call when their name's called, but they don't other times. Or I hear this from families of hearing kids with autism. I know they hear because we can be far, far away. Blue's Clues comes on and they come running. So what is it that's motivating that comes with the auditory skill? Next. Now, I'd say kids with autism, I already said they should get a hearing test. Okay, next, we got 18 minutes. All right, so what are things that can imitate autism? One is intellectual disability. So when you see kids who are progressing slowly, they may actually have lower communication, social interactions from their age level, but not necessarily their developmental level. And, when I think about cognitive development, there's tons of theories. This is maybe in a developmental pediatrician geek, but some are neurologic, some are cognitive, some are social. And really, kids who are deaf and hard of hearing might need a different presentation or approach for language learning. So we got to adapt, but they should still follow that typical trajectory. So a few little areas that I like to just think of. to do at different ages. That 6-month well child check for me when I was a pediatrician, you couldn't get a kid to pay attention to an object. They were so into your face. That, again, that's language, but it's also cognitive. You'll see that mouthing and objects mouthing things, objects becoming interesting at that 6 to 9 month phase. And then you get that simple cause and effect. I'm going to drop it and you're going to pick it up and we're going to have a game of it as long as you'll keep playing with me. And then those kids get to those motor exploration of movement, climbing, they're interested in the reaction of others. Then they kind of move into, well, maybe I'll look at what you're doing and I'll imitate it too. Imitation is a really key component of language learning. And then you see that expanded complex pro-pen play, independence. Around 2, typically we do want to see the understanding of first-then concepts. So first you eat your green beans, then you have a cookie. They're very linked in time. That's a really critical concept for me. And again, I know that's language, but it's also cognitive because it's all intertwined. If you understand that, my approach to you is going to be very different than if you're not there yet. Things around safety, I might have, if you're not there yet, I'm going to have to keep you safe. Timeout isn't going to work very well if your language hasn't gotten to that level. So those things kind of help families recognize what sort of intervention and how to adapt those for those cognitive levels. So a couple of cases. One is a little guy who had an intellectual disability. Well, never mind. I don't know that he has one yet. So he came in. His mom has an intellectual disability, has hearing loss, uses hearing aids. He had a congenital heart repair, and so that put him a little later for his cochlear implant. I think he might have been closer to 2.5 or so. And pre-op, he definitely had delays, and I really thought he was pretty consistent across gross motor, fine motor, cognitive play. So I just thought he had global developmental delay. He did have a post-operative meningitis and required reimplantation. Interestingly, the ENT thought he had autism, and I was like, oh no, I don't think so. I think he just has like a slow learning trajectory. Well, it turns out, next slide, please, ENT was right and the developmental pediatrician was wrong, which is okay. I'm good with that. He was using speech and sign language for his communication. He did do well with adults, but as he got older, it became clear his interactions with peers were challenging, and he became more restricted and repetitive. So he got really into trash trucks, recycle bins. I've had him in clinic where he's videotaped the trash truck that's coming to his house. He's making all the sounds in the video. He's showing me the video in clinic, making all the sounds that's in the sounds that's in the sounds. So he's super pumped about that. He also eventually did more testing, and he did really have a pretty short attention span and hyperactivity. Next slide, please. So his testing did show his cognitive abilities in the range of mild intellectual disability. He did fit autism, which I do agree with, and he still fits that. So he kind of carries 3 labels because that ADHD is also a component of his needs. So what happened to him? He was identified with a chromosomal deletion syndrome. He is at the state school for the deaf, or I think he just graduated, which really did help his communication, both in spoken and sign language. Medications were also helpful. He still has his interest. He also gets a kick out of car air fresheners, those scented air fresheners. So next slide, please. The flip side of this, so we were talking about mimics. So this is my yin and yang. I saw a little boy who was diagnosed with Smith-Lemli-Opitz. It's a very rare disorder where you don't metabolize cholesterol correctly, and it can be associated with intellectual disability and autism. And this family was super engaged. He was in an NIH study. I saw him at about 2 prior to, or just a little before his implant. And yeah, I agree he had developmental delay, but I was very concerned about his eye contact, repetitive play. He could not transition well. I had worries about autism for him. But they were doing everything, and they weren't like eyes were wide open, right? They were doing everything they could to help him. So interestingly, I did not see him for 10 years. I don't know what happened because I put a follow-up. And when I saw him back, he was using predominantly only spoken language, great conversation, engagement, and he did not have anything that I would have said, I think you have autism. So his final diagnosis was mild intellectual disability, and he was a very effective implant user. Another kind of mimic can be what's called nonverbal learning disability, which is not an academically minded disability per se. It's not an educational label, but more known in the neuropsychology realm. So your verbal skills are very good. Your weakness is in visual spatial skills. So these kids might be a little more, they may have some motor delays. They may be more clumsy, but they struggle more with puzzles, but they can talk you through stuff. Kids with spina bifida often have this learning pattern based on their hydrocephalus. But how that affects kids is that it can affect executive functioning, organization, sequencing. Kids can struggle in reading and math, even though we think, why would it affect in reading if you can talk well? But the visual spatial aspect of letters and letter recognition and reading nonverbal cues of others. So sometimes families will say, yeah, I talk to them and I get irritated and I raise my voice at little intervals. And it's not until I'm yelling and then they look up and like, why are you mad at me? Because they didn't see the gradation of those little changes of your irritation. Other things can be communication disorders. We'll talk a little bit about that too. Anxiety disorders can look very much like, autism, especially if they're linked with language. So are you a little OCD? Are you anxious? Do you have social anxiety? So here's another case of a kid who really struggled with imitation. She was really intriguing to me. So she had a later identification of her hearing thresholds, closer to 2.5 to 3. She did fine with hearing aids. She did not, I don't remember the degree, sorry. She had brachiotorenal syndrome. And she was not, even though she was in speech and had amplification, she was not really making very good progress. She did have good visual motor problem solving, but what was really striking in my visit is I was trying to get her to shift from throwing a ball to kicking it. I threw it a few times, she'd throw it back. Then I put it on the ground, kicked it, she'd pick it up and throw it. I'd kick it back, she'd pick it up and throw it. Around. I finally had to put the ball at her foot, make her foot kick it. And then she knew, okay, now I'm going to kick the ball. So she kind of figured it out after that amount of guidance. So imitation is super important, right? It helps us build skills. It helps us shape communicative behavior. And it gives us a window into what kids are how they're seeing the world. Like, who are they imitating? What are they imitating? So she does not have autism, but later she made enough progress receptively that it became apparent she had apraxia of speech. And I would say she also had global apraxia, motor apraxia, with her fine motor and gross motor domains. Other imitations would be ADHD. Kids with impulse control can sometimes not realize other people's space. They might intrude into conversations. They may not process the entire message. They may act before they think. So it's tricky though too, because with the rating forms for ADHD have a lot of overlapping concepts of listening and language, so that's not always clean to figure out. Kids with sensory integration difficulties, they're super sensitive or aversive to things. They're sensory seeking. That could overlap with autism, ADHD, and anxiety. And then I like to put a nod to auditory processing because I really don't understand it. And I know kids who are deaf and hard of hearing are not allowed to have this. But you do sometimes see kids with unilateral or asymmetric hearing loss. It just feels like they have some overlapping features with auditory processing, whether that's attention, language, what. But you just kind of go, you just kind of have a different pattern than what I would typically see in other kids who are deaf and hard of hearing. So my example, this one, when I've made it, I thought it was cleaner. It's a little less clean. So this was a little guy who was identified early, got bilateral implants at a year, has had good cognitive capabilities. Receptive language was good with his implants, but he really struggled with his speech. He could not understand. He was in a program that focused on spoken language, and he was struggling. So he was he was diagnosed with apraxia of speech. He used touch chat to help with his communication, and he made a lot of progress, though still not always clear. Next slide. But he came back about 5 because he was angry. He had trouble following directions. He had a high activity level, short attention span, and would often ask about his schedule. We did get him involved in behavioral intervention, reevaluated him with ADHD and maybe some anxiety. Medication helped a little bit. But school continued to question autism, and then they kind of COVID happened. He has, you can go to the next slide. He has come back, and we have reevaluated him, and he does fit autism. But I do think that ADHD is a pretty strong component, and perhaps why I missed it too. When we think about pragmatics, there's so much aspect of intention, of filtering, of thinking before I speak. So all of these are really those upper cortical factors that we need. So you can go ahead. That's fine. That keeps me going. So what's interesting in kids who are typically hearing, if you have been diagnosed with ADHD, it can delay your recognition of autism by up to 1.5 years, if not a little longer. And they're due, again, the age of recognition of autism for girls tends to be later as well. I think we may not be, maybe our screening tools aren't great. Maybe we are not seeing what families are seeing. Girls tend to have better pretend skills, so people are not picking it up. Obsessive compulsive disorder can mimic autism. Tourette's is a chronic motor and vocal tic that often comes along with obsessive compulsive disorder, ADHD, nonverbal learning. So that can look like autism. Sometimes kids just flap, and that's it's called benign stereotypies, and that doesn't necessarily mean you have autism. And then I think too, sometimes kids who've been in traumatic experiences, attachment issues, I think those are tricky kids to sort through because of their experiences. I've had some kids with absent seizures where they're just kind of missing information and they seem like they're not with us. And that's obviously has a treatment and will help if we treat it. Kids with Usher syndrome who lose their peripheral field cut may look aloof because all of a sudden they're not seeing people say hi. And so you might go, well, what's up with you with your pragmatics? And then there are some other neurologic regression syndromes. So next slide. Okay. 5 minutes. We can do this. Hope y'all okay. Next slide. So what do we know about evidence-based interventions for autism? There is actually a National Professional Developmental Center that keeps track of these with very many evidence-based interventions, but none have been really focused heavily on hard of hearing. So this next slide is just kind of some of those different kind of interventions. So discrete trial training, picture exchange communication, video modeling, and so forth. Next slide. Unfortunately, what do we know for kids who are deaf and hard of hearing? What I could find, and I did, I was all excited because I did another query and I found one more paper, but it was a theoretical framework. So for picture exchange, we have one case series. We have one kid, an example. For video modeling, there's a paper on a theoretical framework and why that might work. ABA, there is a case study, and then there's a framework study. And then there's a Webster Stratton parenting program also has been used in kids with autism, which is a one kid's example. So the paper that I found that was a little more recent that I was kind of excited about, and then I realized it's basically saying, here's things, we've worked with a lot of deaf kids, and we think these can work because, and that's the level we're at. And I really appreciate that they did this because for information about how to support kids, but they do talk about the use of consistency in your instructional strategies, video modeling, visual schedules, social stories. This was a new one to me, using pronoun and power cards. So these are visual aids to teach, that pronouns can be very hard for kids with autism. Am I using my name versus I or me or you? And so those are just some visual supports to help build that. And then peer coaching. We have peers who are kind enough and good-hearted enough to be patient through these different interventions or different ways kids with autism interact. I remember working at a camp for deaf kids who was predominantly signing, and this one kid who was deaf with autism, she would echo everything they said, and then she'd echo anything an adult would say, and then she'd go do it. And the kids were like, "Why is she copying me? Why is she copying me?" And so again, they need to understand this is why, and here's how we can support her. So there was a paper looking at teachers of the deaf and what do they know about evidence-based practice, and about a little over 50% did work with kids with a variety of needs. But there were still varying levels of awareness of those established treatments. So next slide, please. What was concerning, too, is even among those teachers who had experience teaching children with autism, they were asked to rate the effectiveness. And so there was not much consensus on what was effective for deaf and hard of hearing kids. And furthermore, I mean, there were some that they were like more familiar with, prompting, cueing, modeling, schedules, that, that familiarity was more common across most teachers, but it didn't necessarily mean they were implementing. So I think familiarity is great, but we also don't have a lot of evidence to say do this. Next slide, please. So where do we go from here? Well, I think we really got to work across the aisle. We've got to get deaf educators and autism teams working together. They're few and far between where we have that dual expertise. We do need more evidence for what can work with kids who are deaf and hard of hearing with autism. And often kids with disabilities are excluded from studies, and therefore, I get you don't want to necessarily include them across the board, but or you might subgroup analyze them. And then too, like, what is our comparison group? I know I kind of talked about this on the first slide. Why aren't we including them and kids with autism, so that we can understand, are you meeting those, how do we help you? You are in this community too. How do we get you there? Next slide, please. The other thing, like 50 seconds. I didn't focus on family support, but most of the studies out there, whether they're, family experiences, is I feel isolated. I'm not part of the deaf community. I'm not part of the autism community. So we've got to do better there. And so my take home is, don't just assume autism is because they have, their symptoms are related to their hearing thresholds. And I think this group probably realizes that. That's more in my field. Alternatively, don't forget to get a good hearing test on kids with autism. We just need to pay attention to all these kids and be part of solutions. How do we build treatment programs? How do we, kind of build a collective? And then I already gave you my radical middle. We just have to really think about how we support kids overall. And the same kind of ending point, I do really appreciate all the families who've taught me so much. All right.
Thank you. Yeah, it is.
Now, thank you to the interpreters, because I know I'm moving fast. So,
well, thank you for that presentation. It is helpful to know that there is not very much out there, because I think we all feel a little bit stuck sometimes, or we can feel stuck sometimes.
Right. Yeah.
So a lot of kudos and appreciation. Thank you. And then I think there is a question already.
Awesome.
So I think Janet's going to put up the first question.
Well, and I tell kids while that's coming up is, when I'm diagnosing kids, I always tell kids I really love working with people with autism, because they think about things in different ways than I do, and they add neurodiversity to the world. Oh my goodness. So you have a kid who's deaf with autism and deaf parents and who's not signing, and they're not signing by third grade. I don't know. Oh boy, I'd have to, you never want to say never, but that's a worrisome sign to me. And I guess, like, how is the kid communicating, and has that been worked through, and can we still get you to signing? What I learned a really lot from Mary Pat Muller, and she shared with me this resource about fine motor development and signing. And she had a kid who they paired together the speech and the OT to kind of figure out, how do I make my signs more clear? What are the finger patterns I need to be able to do for clarity? And that did really help that child's sign intelligibility. Sitting side by side sometimes is better, because the movement patterns are easier to imitate than reversing them in your head. I would say the person you would want to talk to would be Aaron Shield, and reach out to him. I think he's in the Miami University, maybe. He may actually have some thoughts on how to expand the sign language. Again, I would still say, if you're not abstractly there, you've got to go back down to a picture exchange and move it back up to then building that more abstract. Signs are abstract. I don't know that I have the answers, but so how do we help others adopt establishing communication as more of an emergency than not? I mean, I think we all want to communicate, and I think when we also, in my field, behavior is communication. It's not necessarily, I mean, sometimes behavior is behavior, but most often it's telling us something. And what is it telling us? What are the functions of behavior? So why wouldn't we, if we can frame that up? And I guess too, thinking about what is working. I think you can say system, but sometimes families realize it's not working and then they stop trying because it's not, I've even had families of hearing kids with autism say, oh, I know I should make them use their words. And I usually say, right now you're doing what's working. You are doing what you can function through, but we're going to need to figure out more ways. So let's get you the right help to figure out those ways to expand. Don't take that guilt and just say, oh, you just need to wait them out and make them talk. That's, that isn't always how it's going to go. I don't know if I'm answering that question very well, but, we all want to communicate. We all want to be part of things. And I know parents can read their kids well, but then there's other people they need to be able to communicate with. So the fine motor book is out of print, and I just have a copy, and I copy it and I give it to families. So maybe what I can do is at least tell you what I'll have to, I just honestly have it. It's this thick, and I copy it off for families, so I'll have to send that information afterwards. I've made it in a PDF. It's really long. What I like about it is it really does go through what's easier to produce, what's harder. So hands together, hands down, hands up is hard. Like a supination, hands up is a harder thing. Any sign that is touching you or uses the same movement pattern across is easier to make. So that's, more is touching and it's the same movement. If I have to cross midline, those sorts of things. And then it also does a nice job of thinking about what is a kid motivated to sign about and how do we build those skills. It's really interesting if you have that interest.
Can you send that PDF to Lisa, please?
I can. I think I can. I mean, I got it. Since it's out of print, I don't think there's a copyright piece to it. I have no idea. I literally just copied it when I visited Boys Town years and years ago. I mean, it's really old, but I don't think it's changed because your motor patterns are established. I think that hierarchy is not arguable.
Well, since there's not another question immediately coming up, I'll interject. Oh, here's the question. Sorry, I don't want to take.
Oh, no. Language deprivation versus autism. I think, I was involved in a case series. They ended up putting it in a journal, this kid who went through spoken language and then went to a sign language program. And most of the authors talked about language deprivation as the issue. And if they had started with sign language, that would have been different. However, in the 2 years of being in that ASL program, the kid hadn't made progress either. In my mind, that's a language disorder. Either modality, he made about the same amount of progress. So when you think about bilingual kids and where there's their language learning when they have a language impairment, they should be kind of commensurate. So I think, again, even in language deprived kids, if audition isn't working for them, they still should have pretend play. They should have communicative intent. I have kids that make up their own gestures to get their point across. They are highly communicative, if not idiosyncratic in their signing. That's not autism. I really look at that core social engagement, pretend, and not just where their language level is. I don't know if I'm answering that question, but it's not. And that's why I struggle. I mean, I do struggle because when I've gone back and looked at the kids that I later identified with autism, when I was younger and not seeing it, all of my descriptors were there. And if I read my note, I'd be like, oh, geez, I had to do this to get their attention. I couldn't shift them. And I'm like, why didn't I see it at the time? Like, I mean, I was young and now I see it. But those things are there often very young. And it's a quality. I don't know how to say it differently, but you really have to be watching for those. Again, almost like what's not there. You're seeing what's not there. They're not looking at you. They're not pointing. They're not gesturing. So you're having to find it's not the idiot. It's not the perseverations or the echoing yet because you don't have enough to get there.
How do you work around the families who aren't quite ready to hear?
Oh, I think so. A lot of times too, I will, especially pre-implant. Some of these kids look concerning pre-implant. And I realize that they have to go through, they have to see that it's not the hearing. And as long as they're intervening appropriately, I can give them a little more time. If they're choosing not to intervene with extra stuff that we think they need, then I'm more worried about, like, how do I help you get what you need? Because what I don't want, even if I label you later, if you got what you needed, the delay is less problematic. So are you worried about this? Or are you worried about that? Let's add some occupational therapy to work on adult-directed activities or, expanding out your play. So I will throw some other services in and then say, I'm seeing this. I just want to see you after the implant because if things are better, great. If they're not, I want to make sure we have a plan in place. And sometimes I will say I'm not seeing them first. So it's super helpful that other people have raised those questions because sometimes I'll go, what have people said? What are you worried about? What's grandma say? Then the next question is when you haven't used your amplification. So I'm going to go back to, even if you don't have acoustic access, I would expect some communication skills to have occurred. And I've had some kids who literally, I know have autism, hate their implant. And I've had a family in rural Kentucky get told, not by our audiologist, but by some school, that if you don't get this kid wearing this, we're going to call children's services on you. And I had to write a note that said, look, this isn't going to work. It's okay. The kid's allowed to be deaf. They also have autism. Let's figure out the communication approach. It's not necessarily going to be acoustic access. I have kids who have stopped using their implants with autism and kids who auditorily perseverate on overheard conversation with their implant. It's the whole board. So it is about the autism. It's not as much about the hearing. That's because I just don't think there's one pathway especially not for these kids. I don't know. I'm very passionate because you got to meet them where they're at. And yeah, sometimes kids will come back and they try again and maybe we can get better, acceptability. I also work with a phenomenal group of people who can think about how to map a kid without overstimulating them. So, big kudos to Michael Scott, who, if you know him, I love him to pieces because he really tries to stand on his head to figure out what do we do to help with acceptability of implant. Bringing in OT, is it the device sitting there? Is it on? Is it off? Like, do you start low and build up that? Because again, you think about these kids with autism with almost hyper hearing, right? They're going to cover their ears because it's just too bothersome. We don't know how these kids are receiving that input. That was a long answer. Sorry. So preschooler who doesn't do well, he's a Roman crash. I think so. When I think about what's the right placement, I think about the predominant need. And are you, as a deaf, hard of hearing person, the key person, or is somebody else? And are you supplemental or are you primary? And maybe this kid would be better in a integrated special education classroom with DHH support. So is that setting a little bit different? And will the skill set of that teacher help? And again, that kid probably does need a para. And there's a lot probably more behind that story. But yeah, I think about, even with autism, like I have some kids where I was very frustrated that the ABA program wouldn't take them because they needed to build foundational stuff. It didn't matter at that point if they were hearing well through their implant or not. They weren't getting that very basic thing. So I was disappointed they wouldn't try. But I get these systems are very separate. And again, the family, I think too, it's hard when families, sometimes when kids are in programs, they see other DHH kids, they realize their kid is learning differently, and that helps. And other times they're still really focused on this is hearing, and so this is the right place. And so how do you kind of open up that door of what are some things your child needs that we need to think about and support? I don't have any answers. I do and I don't, right? Because it's all individually.
But you have such a rich experience.
Oh yeah, families have taught me, families and kids, and I've seen them over time, so I know when I've messed up.
And it is the further you get along, the more you learn from them, right?
Yeah. Right. And I recycle family knowledge greatly. Like, oh, this was something that worked. I'm like, yeah.
Do you have any special advice for families who prefer their care in languages other than English?
Well, I think we really did a disservice as a field when we used to say speak English because that's where they're going to school. Mm-hmm. So I really try to promote inclusion and bilingualism because you've got a whole family you want to talk to, and that's your culture. And so if we don't respect that, I think we're really doing a disservice to kids and families. So I think, again, I usually say you're going to learn them about the same pace, right? I mean, yes. Kids code switch, but sure, if I'm learning more slowly, and there may be a dominant language because they're in school so long, and so then that's even more reason to speak your natural language at home, like because they're not going to get it at school. Yes, I don't know. That's not
Well, that was our topic last year, certainly. So
did I align or not?
Yeah, absolutely. Okay. Absolutely. And I guess my question was more for families who may have certain challenges or barriers to navigating the system.
Oh, yeah.
Because the system is so complicated. And
I think there's a lot of more coming out on family navigation and community workers. So people from the community helping with navigation and understanding. Like we have one of our newer faculty who is from Peru did a whole promotores de salud approach for autism. Can we get the community understanding the red flags and risks for autism and what to do about it? And honestly, with the CDC data recently, we are seeing changes in earlier access among certain populations. But yeah, it's hard. Yeah, it's hard for me, of somebody on the inside, to navigate, let alone all of those other factors.
Thank you.
We make it hard, right? We put hoops. In fact, there was we stopped using questionnaires to enter, and there was a whole series about this at SDBP, and people were still really stuck on their questionnaires. And I basically was like, you're putting a barrier. If that's what you're doing for access, just know that's what you're doing. Like, you can't handle the access, but you've just put barriers in place for families who need you. So I'm opinionated.
Thank you. We're going to move on to collaborative care and breakout rooms. So we'll hand it over to Terra. And let's see. Lisa. So are we going to move to the next slide? So I'm going to introduce Terra Boulse-Archaro, who is one of our oral habilitation specialists and our lead AH provider.
Hi, everybody. Thank you, Dr. Well. I really appreciate it. I've heard you speak many times, and it's always super motivating, and so I appreciate both of your talks today. So hopefully I can piggyback a little bit off of some of your presentation. We're going to talk a little bit about collaborative care today, and how we can collaborate and support families and children who are medically complex, who have hearing differences. So those of us who work with kiddos with hearing differences, we're quite skilled if we have a kiddo who just has a known hearing loss, and how we can support those families and find out what the family's goals are. But when a child with hearing differences has additional medical diagnoses, this process can be complicated. and the recommendations not be as clear. So I hope today's presentation we can talk about why it's needed and maybe a little bit about how we can collaborate a little bit better for kiddos who are medically complex. And so my disclosures are I am an employee of Seattle Children's Hospital and also a member of ASHA. And I'm also going to start my time here because I know that we really want to get to the parent panel, which I'm really excited about that after today's talk. Great. So the objective today is to recognize the importance of collaboration, care, and teamwork, and to ensure that children who are deaf and hard of hearing with additional disabilities have the opportunities to meet their full potential. So let's get out your phone and your piece of paper. I just like to know who's in the audience when I'm presenting. So if you can get into Slido really quick and just let me know which of the following best describes your current role.
It in the Slido part, so you've got 34% audiologist, 28% speech, 21% teacher of the deaf, 11% other, 6% parent, 2% special ed teacher.
Great. Thank you. Thank you for that. Great. Okay, great. We have a nice variety. So what is teaming? So in the business world, teaming can be defined as coordinating and collaborating with people across boundaries of all kinds to get work done. But we are in a business field of some sort, but that is not our responsibility primarily. We are working with children and families who are all different, some complicated and unique in their own ways. And so instead of the business term of teaming, I like to think of it as we're coordinating and collaborating with people who have a shared goal of improving outcomes for a child and their family. And so that's what I like to think about when I think about teaming. So what's needed for effective teaming? And we're going to take these one at a time. So for effective teaming for medically complex kiddos, business professor Amy Edmondson, she identified three key needs for effective teaming. And the first thing we need is humility. So it's okay. It's okay that we may not know the answer, and it's okay. It should be okay for us to know and reach out for help when we don't know. So knowing when we don't know and knowing when we might need help. Secondly, we need to remind ourselves to be curious about what others bring to the team and not get stuck in a professional culture class or silo. So not doing what we've always done because we know what we do, but instead, how can we team, adapt, work together? We want to be curious and find other ways in how we might provide care. We want to look to our other professionals and partner with them so that we can see things through a new lens. And if we come to the table with humility and curiosity, then in turn, we're going to have psychological safety. And that allows us to take risks when we are working with a group of people with a shared goal who are also curious and trying to find the best possible outcome together. So especially when we're looking at working with kiddos who are deaf and hard of hearing, who have complex, who are medically complex, we really need to partner together. We really need to work together to try and figure out how we would work with these kiddos. So what we're going to do today is this first case study we're going to look at together. And then we're going to do a second case study where we're going to break out into breakout rooms and we're going to try and figure out how we might approach the complexity of the patients that we're seeing. So please know that both of the case studies that we represent today, these are a combination of facts about kiddos that I've worked with over the last 20 years. Some of the families and professionals who have maybe seen these kids might be in the audience today. So I just want you to keep that in mind as we talk about these different cases. So the first kid I want to discuss, she's a sweet girl I met for the first time at 6 months of age. We're going to call her Susie. And she was born full term. There wasn't any significant pregnancy or delivery complications. There's not a family history of hearing loss. She referred on her newborn hearing screen and was identified with a moderate to severe sensorineural hearing loss, the left mild sensorineural hearing loss. She was fit appropriately with hearing aids by 3 months of age. She was referred for early intervention, and spoken English was at home. So I want you to take out a piece of paper really quick, or your phone or whatever you want to take notes. We're going to go a little bit old school here for a second. And what I want you to do is think about, because this is a common profile of a kiddo that we might see who has hearing loss, I want you to sort of think about what would some of the professionals, or actually let's go to the next slide. Let's think about who would you want her to be part of that collaborative team. So this is again on Slido. Just based on that, she was born full term. There weren't any significant pregnancy delivery complications. There's not a family history of hearing loss. She has asymmetric hearing loss. Yeah, great. Audiologist, SLP. Great. Anybody else that you might? Yep, TOD. Good. Okay, let's wait for that one to pop in. ENT. Right. That's generally It's generally who we would have in her plan of care. All right, so let's think about Susie again for a second. Oh, good. Oh, great. Genetics, CI specialist, parents, of course. Thank you for parents. Yes, they are the most important team members in our group. Perfect. Great. Okay. All right, so get out your piece of paper again. Here in Seattle, a child who would have this profile would be met by a family resource coordinator, and they might discuss early intervention options. And so in this case, the family opted for early intervention through Listen and Talk, which is an early intervention program in Seattle that focuses on listening and spoken language. And so even though the family enrolled in Listen and Talk and their primary focus for communication is listening and spoken language, the family also wanted to learn some sign, and they would like some guidance from a deaf mentor. So they really wanted to include all types of communication. All right, so let's go ahead and push the next. So early intervention services began with Listen and Talk. Listening and spoken language was the primary. And then next bullet. Great. So then a little time later, as she's working through that early intervention process, she was diagnosed with having developmental delays and was having some obvious, gross, and fine motor delays. So just take a second, take a pause for a minute. And even though we're not going to do it on Slido, what service providers do you think you would add now to her program, knowing that she has developmental delays? Great. So now we are thinking about other things, about maybe other ways that we might want to include. So maybe now we have PT involved. Maybe now we have occupational therapy involved. Maybe now she's going to be seen by a developmental pediatrician because we have a little bit more complexity. And do you think just by that one fact alone, does that change at all how you might approach her social development or cognitive development or language goals? All right, great. All right, so let's do the next bullet. So then, as time goes on, we notice that her hearing seems to be progressing, and she is now has a pretty significant hearing loss on both sides. It did take a while, as Dr. Riley had shown us earlier. It took a while for behavioral testing, and she had many behavioral tests before finally the family or the audiologist recommended that she get a BEAR or an ABR, and then that did definitely let us know that she had a progressive hearing loss. So now the child has a progressive hearing loss, and so now on your paper again, write what professionals do you think you might include at this point, now that we know that she has a progressive hearing loss, and how we might change her goals with the family's thought of wanting spoken language in mind. And so if we think about that, the family did want to proceed with a cochlear implant because spoken language was their primary focus. And so now we've had that. Okay, next bullet point. So during this period of time, she also started to develop seizures. And the seizures happened sometimes daily. Sometimes she would go with weeks without a seizure. Sometimes she even went a few months without a seizure, and then she was happening daily again. And these seizures would lead to this point where she would hold her breath for 20 seconds, occasionally needing rescue breaths to bring her back. And this was happening multiple times a day. They were trying to use medication to help stop the seizing. And so now think again, now what professionals might we add to her program? And what other team members should be involved? So certainly neurology, and now think about how with the increase of seizure activity, how might we change her program again? Her social, and think about her social language, her cognitive development, her language goals. All right, next bullet. And then once we looked at some scans of her head, they realized that she had partial agenesis of her corpus callosum. So the right and left hemispheres were not able to communicate with one another, or at least partially. That was a really challenging thing for her. And so then again, we need to reassess, okay, how is this going to impact her language? How is this going to impact her cognition? How is this going to impact her motor? Next bullet. And then a little while later, they determined that she probably had CVI, or cortical vision impairment. So again, thinking about how is that going to impact her language, her cognitive development, her social. And so we go through this. I had to go through this process because with each piece of new information, we really had to adapt and to modify how we might think about helping Susie and working together as a team. It started off with just a small group perhaps, and then the team expanded and expanded and expanded. And so we need to think about all of the different aspects of Susie as we're trying to help her along this journey. Next slide, please. Oh, and then she had a cochlear implant at 18 months, and that was, again, her hearing loss actually progressed quite quickly. Did take a while to get that information, and so she received her implant at 18 months. So I love this quote. Again, it's hard to learn if you already know. So I think about this because, the most effective teams that we can be a part of are those who are humble and those who are curious. And so you think you may know your own area very well, and we all do. We've all worked for quite some time, but we can enhance that learning as we work with others. And when I think about that, it's not just making a referral to somebody or giving the family a number of a phone call to call, but instead really taking a deep dive with the team that you're with, the professionals that you're working with, to really truly learn and personalize the plan for the child and the family that you're serving. So what is successful collaboration with medically complex kiddos with hearing loss? What does that look like? So we can't possibly know the best way forward to help Susie's outcomes without this collaboration. It's not something that one person can take on their own. Remember that humility and curiosity create psychological safety so that really we can work together to help improve the outcomes for Susie. So how do we do this? Well, we have shared goals. The family, and then support those shared goals that we have. We also want to know who is the best person to support the family, and how does the family want to be supported? Not just what can we do for them, but what can we do for them today and right now? What's the best way to do that? And are we able to, and how do we adapt when a new diagnosis or a new challenge comes along? Remembering to be curious and remind others to be curious. So although the information that we have or how we are helping a family in one environment, if they go to a different environment, they may need a different type of support. And so really thinking about strategies across all environments or all situations or with a new diagnosis, and how can we support one another, support the family. I think having really defined roles can be really helpful. Everybody working on the team has a role, but it may not be evident to the family about what your role is on the team, and it may not be evident to other members on the team of what your role is. So really talking about together who is working on what, or how are you collaborating to work together for specific goals. The other thing is how to determine the best method to share information. So when we're working with families, I know we all are working hard. We're really trying to advocate for families. We're working one-on-one. But is there a shared space to get updates for the family? Or is there a shared space that all professionals can communicate with one another? Schools often have a communication notebook. I did teletherapy with a family, and the mom had a notebook, and she would take notes in her own notebook. So she was the collector of all the information. Is there a virtual way that we can create a list of all the people who are involved here, not just within a IFSP, but the medical professionals as well, and then talk about new things that have happened or new diagnoses or just new updates on the child to keep everybody aware. And then always monitoring and modifying. So even though we have a set of goals, if there is another medical complexity that changes the outcome or changes if the child's stable or how stable they are, we constantly are going to need to monitor and modify how we're serving the families. When I think about working with families who are medically complex, I do think about these questions, certainly. So what are the goals of the family? What are the overall goals of the family? Maybe, as I said earlier, what are the goals for today? What are the goals for this week? Because maybe just getting through the week, maybe not having her have a seizure that day, which is not maybe a goal that we can help, but certainly a goal that we can support with families. Do we have all the information that we need? Is there that shared document where we can get the most updated medical information for this family? Is there a place where we can really reach out and collaborate together as a group? Are there barriers to receiving care? Are there financial barriers? Are there emotional barriers? Do we not have the right providers of the appropriate services? And again, what does that child and family need today? Are the services that I want to provide adding value? So because we have a child who has a specific diagnosis and said that this specific professional should serve this child, but is the care that we're providing actually added value, or would we be better off if we were pairing with another provider? Would we be better if we're co-treating with another provider so that it's not another appointment that the family needs to attend just to attend because it's another provider that they're supposed to be seeing? But are there ways that we can think creatively about how we serve the family so it's not just another appointment that they need to attend? So I love this. When in doubt, reach out, right? If you have a question, if you're asking yourself, is there a better way that I could be serving this family? Or am I doing this right? Is this not the way that we would do it? And when in doubt, reach out, collaborate. Remember, we want to be humble. We want to be curious. And it's okay. And if we do that, it really creates a safe space for us to go ahead and reach out. And there isn't a dumb question. The only dumb question is the one that we don't ask. And so we really want to reach out and work together for the family. I borrowed this from Dr. Wiley's presentation a little bit, and then I took it a step further because I really love it. When we think about communication, what does the child hear? But not just what do they hear? How do we know what they hear? Were we able to figure that out? How does the child understand the message? And how do we know if they understand the message? What are some behaviors or some ways that we're seeing that? Does the child have the ability to respond to the message? Are we asking too much? Can they respond via speech or sign or gestures or facial expressions or body movements? And is it consistent from day to day, or does it change from day to day? What are the child's strengths, and how can we build on those strengths to help them for their overall development and their communication? And again, what are the barriers to the communication? Maybe the child has, again, developmental delays and motor delays or fatigue, or maybe the time of day that they have to take the medication specifically for seizures. Could that impact how they're going to communicate, and if that communication can be consistent from day to day? So Susie today, she is a happy 11-year-old. She loves her family, cuddling with her sister, and she loves swinging. She eventually did get a diagnosis that included epilepsy. She's a consistent user of her cochlear implant. She's an auditory learner. That was the best. Receiving a cochlear implant was actually the best way into her world because that really is how she takes in information. And she is in a resource classroom. She has para support, nursing support, and one of the factors of her is that because the seizures really impacted how she is able to communicate from day to day. And so we didn't, even though she initially started at Listen and Talk, we really wanted to help her get information in all the ways: vocalizations, AAC, gestures, modified sign language. And then we also wanted her to be able to express the easiest way possible for her from day to day. And so she also used all of those methods for communication, and had been really impactful. So I would see her for therapy weekly, and it was a new day every day because I didn't know how the best way for information was going to get in or out that day. And so we just took it day by day. Great. All right. So now it's your turn. So we're going to talk a little bit about Johnny. Johnny I'm going to give you a little bit of background information, and then what we're going to do is you're going to be put into breakout rooms, and I'm going to ask you about 3 questions that I want you to talk about in your breakout rooms. So Johnny was identified with Down syndrome in utero. His family was aware that he was going to be born with Down syndrome. They were highly motivated and connected with lots of groups. They felt very supported even before he was born, and of all the needs that he was going to need or likely need once he was born. And then when he was born, he referred on his newborn hearing screen, and he ultimately was diagnosed with the bilateral profound hearing loss. So that was, right, you think the child that you're going to have is the child that you're going to have. And then again, they had a new story right when he was born. He ultimately received cochlear implants at 18 months of age, and that was delayed not for lack of support from all the professionals and the parents, but he had middle ear involvement, and so that just delayed his cochlear implant surgery. Next slide, please. So he received appropriate birth to 3 services. He received OT, PT, speech therapy. He received and then he received services specific to his hearing loss. He had consistent device use. He was exposed to spoken and sign language, but he really made minimal progress in both. There was a lack of overall communication and play progress. He had really poor, limited attention. He was very fixated on parts of toys, but not playing with toys themselves in a functional way or in a pretend way play. He had really limited social reciprocity. And when I met him, he was around 3 or just before 3, and he was going to be transitioning to preschool services. All right, so this is where you get to do some breakout. So go ahead and next slide, please. For this breakout, for the breakout questions, I really want you to think about, I think they're going to put his profile in the chat, so you don't have to remember all of that. But what professionals do you think you want to be involved in Johnny's care program? And remember, not just, lines on an IFSP, but really, who do you think needs to work together to collaborate to figure out how to serve his needs? Question is, do we have enough information, and what information do we need? And then how do we guide the family to make an appropriate preschool educational placement? And then how are we going to share that information? So again, we're going to have a very short time, so we're going to have to be efficient. But I think those are the main questions. What professionals? Do we need more information? Do we have any idea about what we might recommend for a preschool educational placement? And then how are we as a group going to share this information among all group members? All right. And hopefully our breakout groups are all set up, and we can break away, and then we're going to come back and discuss. All right. Well, so moving on, because we definitely want to get to their parent panel. So barriers to collaboration. And I think these are not anything that we don't know, but I just like to point them out, and that lack of trust. If we're not being humble and curious as we're coming to the table when working with kids who are medically complex, there could be that lack of trust. Maybe lack of awareness of the medical diagnoses, maybe lack of awareness of what we don't know. That could be a barrier of collaboration. Staying in silos. I only work with kids with hearing loss. I don't go into the vision realm. I don't go into kids with developmental delays, and not really looking at the child's full situation. The lack of lead or a shared avenue for collaboration. In many of my cases, the families have taken the lead, and have really been the ones to make sure that all the providers are collaborating with one another. But if a family doesn't do that, who's going to do that? And the family has a lot to manage on their own. And so how can we support them in that? If we have clashing perceptions and approaches, I think that we've talked a lot today about that. Really, not necessarily. We are seeing kids that may not follow a normal developmental sequence, and so let's give them all the things, because we really don't know, especially in the beginning, how they're going to receive information and how that information is going to be communicated back to us. And so giving them all the options and not getting stuck in one approach versus another, but really looking at what the child is able to do and really looking at their strengths. And then, is there a mismatch again? Are we asking them to do something that they're not able to do? And is there a way that we can have a bridge to help them do that or go lower? Which is often the case in kiddos who are with autism, who don't have that social reciprocity. And then time, right? Collaboration takes a lot of time. And it can be hard to get in touch with everybody, but really a little bit of collaboration goes a long way for the family, and then for the next kiddo that you see that may have some similar difficulties. And we've talked a little bit about it today, but to be effective collaborators, you really need to be persistent, not just do what you've always done, but really try and adapt to the needs of the child and the changing needs of the child. Be curious. If you don't know, it's okay. When in doubt, ask, right? Be strong advocates for the family, because they are often trying to navigate a really complex world with lots of complex diagnoses, medical conditions, professionals, appointments. And so we can be those strong advocates for the family. Again, be humble. It's okay to not know. We can learn together and have a shared responsibility, not just this is my one role and this is my one job on this team and that's all we're going to do, but let's work together. How can we figure out how to help the families? Be respectful of where the families are at, and then non-punitive. It's okay to ask questions. It's okay if you don't know. The more that you ask, the more that you'll be able to learn. And then just being flexible, taking new approaches or new ideas from others and seeing how that can be integrated into helping the outcomes of the child overall. And thank you. And I am looking forward to meeting with the families. I think now we're going to take a quick break. Is that right?